Hello friend, today we'll discuss a long case of, internal medicine, that is rheumatoid arthritis. So firstly I will discuss some information from HAMAD, a book of MRCP medicine. Then I will discuss it from Davidson and some points from Harrison. So firstly I am discussing some information from the HAMAD. So in the HAMAD, it is written rheumatoid arthritis. Rheumatoid arthritis is strongly associated with some genetic predisposition, genetic association, that is HLA-DR4. And tumor necrosis factor is the key role, plays a key role in the pathophysiology of rheumatoid arthritis. About such as 70% of the rheumatoid arthritis patient having association with HLA-DR4. And those who are advanced disease who developed Fentis syndrome, that is the combination of rheumatoid arthritis, splenomegaly and pancytopenia or neutropenia, that are strongly associated with HLA-DR4, that is 90% associated with HLA-DR4. Prevalence epidemiology, usually epidemiology prevalence is 1% among the general population. So male female ratio is 3:1, but in the early stage, but when the age increases, it is closer to 1.1. Peak age of onset is 30 to 50 years of age. The exact etiology is unknown, so there are some genetic association, that is HLA-DR4, and there are some infection associated with, like UTI due to Proteus mirabilis. Infection is very common, that is a gram-negative anaerobic rot in the the fecal flora. So what are the cytokines are responsible in the pathophysiology? That is most commonly tumor necrosis factor 1, then interleukin 1, interleukin 6 are abundant in the joint fluid. Tumor necrosis factor is secreted by macrophages, and there are some blocker, some biologics which act against tumor necrosis factor, like infliximab, etanercept, are now licensed for the treatment of severe rheumatoid arthritis. Rheumatoid arthritis involves pannus formation. So it involves pannus formation. It is which leads to cartilage destruction and joint anycholysis. Pannus is an abnormal layer of fibrovascular tissue or granulation tissue that ultimately destroy joint tissue. So how it is diagnosed? There are some diagnostic criteria. As per American College of Rheumatology, there is some diagnostic criteria, but it is strongly associated with anti-CCP, that is anti-cyclic cytolinated peptide, which are very specific with the diagnosis of rheumatoid arthritis. So what are the, as per American College of Rheumatology, so there are 4 factors: number of joint involvement, number and serology, then acute phase reactant, and duration of symptoms. So as per, at least there should be 6 point out of 10. So if someone's score is above 6, so he is supposed to have rheumatoid arthritis. So number of the joint involvement, if the one large joint is involved, the serology score is 0. If 2 to 10 large joint is involved, serology score is 1. Small joints involvement, 1 to 3 small joints involvement with or without involvement of the large joint, score is 2. 4 to 10 small joint involvement with or without involvement of the large joint, score is 3. 10 small joint involvement or 10 joint involvement, at least one small joint involvement, score is 5. So small joints, more number of the small joints involvement is associated with more score. Serology, at least one test is needed for the classification. If the rheumatoid factor and anti-CCPA is negative, then score is 0. If there is low titer, that is less than 3 times of the upper limit of the lumbar, lower limit of the upper limit of the normal range, that is in case of rheumatoid factor, and in case of anti-CCP, the score is 2, raised but less than 3 times of the upper limit. raised and more than 3 times of the upper limit, then score is 3. If CRP and ESR both are normal, then score is 0. If one is abnormal, either ESR or CRP or in combination, score is 1. Duration of the symptoms, if duration of the symptoms is less than 6 weeks, score is 0. Duration of weeks is more than 6 weeks, score is 1. Rheumatoid arthritis typically affect the metacarpophalangeal joint and proximal interphalangeal joint symmetrically. Psoriatic arthritis involves distal interphalangeal joint and tends to be asymmetrical. So rheumatoid arthritis involves the metacarpophalangeal joint and PIP, and it is usually symmetrical. Psoriatic arthritis involves DIP and PIP and usually asymmetrical, and it is very sometimes confused with osteoarthritis, so we need to differentiate it from osteoarthritis. Osteoarthritis, the joint pain is inflammatory in nature in case of rheumatoid arthritis, that is, pain occurs in rest and decreases with activity, and pain in the osteoarthritis is mechanical in nature, that is, rest reduces pain and activity increases pain. Age of starting, rheumatoid arthritis can occur at any age. Osteoarthritis occur at the later stage of the life. Spread of onset rapid over weeks to month in case of rheumatoid arthritis, slow and over the years in case of the osteoarthritis. Pain improves with movement or activity in case of rheumatoid arthritis, worse with the movement and better with rest in case of the osteoarthritis, that is mechanical in nature. Primary joint affected in case of rheumatoid arthritis, that is the metacarpophalangeal joint and proximal interphalangeal joint. And in case of osteoarthritis, it is metacarpal joint in the wrist, and distal interphalangeal joint are most commonly involved. Haberden's node are absent in case of rheumatoid arthritis, present in osteoarthritis. Joints become soft, warm and tender in case of rheumatoid arthritis. Joints become hard and bony, usually little or no swelling in case of osteoarthritis. Morning stiffness is more than 1 hour in case of rheumatoid arthritis, usually less than 30 minutes in case of osteoarthritis. Systemic symptoms more common in case of rheumatoid arthritis. Systemic symptoms is absent or very mild in case of osteoarthritis. RF, rheumatoid factor anti-CCP, is positive in case of rheumatoid arthritis, negative with the osteoarthritis. ESR and C-reactive protein elevated in case of active rheumatoid arthritis and normal in osteoarthritis. X-ray shows osteophytes in case of osteoarthritis, and there is no osteophyte in case of rheumatoid arthritis. There is periarticular osteoporosis and joint destruction. So here we can see there in case the two film rheumatoid osteoarthritis patients have the joints are fused together and there is thin cartilage and osteophyte is there. There is osteophyte. And here in case of rheumatoid arthritis, joint is swollen and there is increased joint space, sometimes ankylosing. There is joint bone erosion and synovial, and there is a periarticular osteoporosis is present in case of rheumatoid arthritis. So there are lots of joint deformity occurs in case of what are the arthritic findings of rheumatoid arthritis. So rheumatoid arthritis is the inflammatory arthritis, that is the symmetrical arthritis of small joints of hands and feet, and which lasted more than 6 weeks, and it involves proximal interphalangeal joint, metacarp or metatarsophalangeal joint and wrist joint, and sacroiliac joint is spared in case of rheumatoid arthritis. Rheumatoid nodules over the extensor surface of the tendons are present in case of rheumatoid arthritis. Vascularity skin involvement is present in case of rheumatoid arthritis. Usually there are some joint deformity in case of rheumatoid arthritis like swan neck deformity, DIP hyperextension, and PIP hyperextension are present. There is boutonniere deformity, PIP flexion and DIP hyperextension are present. Ulnar deviations may be present in case of rheumatoid arthritis. So there are different types of deformity like swan neck deformity, boutonniere deformity, ulnar deviation of the metacarpophalangeal joints are present in case of rheumatoid arthritis. If we do the lab test of synovial fluid, we will get abundant neutrophils and high protein level. So in the investigation we will get ESR and CR reactive protein will be elevated. Up to 40% of the patient with rheumatoid arthritis have normal level of ESR or CRP. A normal CRP C-reactive protein can help to exclude the diagnosis of inflammatory arthritis. A normal C-reactive protein can help to exclude the diagnosis of inflammatory arthritis, but elevated level is never a specific finding. Rheumatoid factor is positive about 60 to 70% of the cases. Now few points about NT-CCP. Positive NT-CCP is a prognostic marker. NT-CCP may be detectable up to 10 years before development of rheumatoid arthritis. So up to 10 years before development of rheumatoid arthritis, NT-CCP may be present. It may therefore play a role in the future rheumatoid arthritis. It allows early detection of rheumatoid arthritis. It has sensitivity similar to rheumatoid factor, 70 to 80%, with higher specificity, 90 to 95%. Nice knee comment: all patients with suspected rheumatoid arthritis with rheumatoid factor negative should be tested for NT-CCP antibody. Nice state that considering measuring NT-CCP antibodies in the people with suspected rheumatoid factor, if they are negative for rheumatoid factor, if there is a need to inform the decision making about combination therapy. ANA may be positive 20 to 30% cases of rheumatoid arthritis patient. Now the X-ray findings of rheumatoid arthritis. At early stage, most likely investigation that will help a diagnosis are X-ray. So at the stage of early rheumatoid arthritis, the most important investigation is the X-ray of the hand and X-ray of the foot, where we can get periarticular osteopenia and marginal erosion. So periarticular osteopenia with marginal erosion can be early findings of rheumatoid arthritis. Periarticular osteopenia and osteoporosis would point a diagnosis of rheumatoid arthritis. Loss of joint space is common in case of rheumatoid arthritis and osteoarthritis, and also in pseudogout. So what are the radiographic features of rheumatoid arthritis? That is loss of joint space, there are erosion, soft tissue swelling, and osteopenia. Early X-ray findings: loss of joint space, periarticular osteoporosis or osteopenia, soft tissue swelling. Late X-ray findings: periarticular erosion and subluxation or joint deformity. What are the prognostic factor, poor prognostic factor of rheumatoid arthritis? NT-CCP is a very poor prognostic factor. High rheumatoid factor So if a patient having high rheumatoid factor, high NTCCP, AHLA DR4 positive, if it is sudden or acute onset, and poor functional status at presentation with disability, patient presented with disability, and X-ray finding showing erosion, and with having some extraarticular features like rheumatoid nodule and female sex are associated with poor prognosis. So what are poor prognosis? NTCCP, rheumatoid factor, HLA DR4, acute onset, poor functional status, early erosion, rheumatoid nodule and female sex. Rheumatoid arthritis patients have increased risk of development of ischemic heart disease. A patient of rheumatoid arthritis may develop Becker cyst due to persistent effusion in the knee joint. What are the extra articular complications of rheumatoid arthritis? It may involve eye, and 25% of the patient having eye problem. That is keratoconjunctivitis sicca, that is dry eye. So dry, burning and gritty eye. Keratoconjunctivitis sicca, then it may be associated with episcleritis, that is erythema, scleritis, erythema and pain in the eye, corneal ulceration, keratitis, and sometimes drug-induced, steroid-induced cataract may develop, and chloroquine-induced retinopathy may develop in case of treating rheumatoid arthritis. So it may affect heart. Constrictive pericarditis is the commonest cardiac complication of rheumatoid arthritis. It may develop ischemic heart disease. There are some respiratory complications like pulmonary fibrosis, pulmonary effusion, rheumatoid pulmonary effusion, that will have low glucose level in the fluid, pulmonary nodule, bronchiolitis obliterans, methotrexate pneumonitis, pleurisy. So in the bone, it can cause osteoporosis and cord compression. So cord compression can lead to death, especially atlantoaxial subluxation can lead to sudden cord compression and sudden death. So X-ray of the cervical spine in flexion and extension with MRI of the cervical spine is required to detect atlantoaxial subluxation and neurosurgical intervention. So the patient of rheumatoid arthritis having more chance to development of infection with Proteus mirabilis. Less common complications are Feltis syndrome, that is advanced rheumatoid arthritis with having splenomegaly and thrombocytopenia, sometimes low WBC count, anemia, neutropenia, thrombocytopenia. Usually rheumatoid arthritic patient having thrombocytosis, but here we will get thrombocytopenia with neutropenia. So that is burnt out rheumatoid arthritis and patient having splenomegaly. So sometimes they develop amyloidosis, and amyloidosis lead to nephrotic syndrome, and ultimately that can lead to fluid overload in the body, and it can lead to systemic amyloidosis also. So how it can be diagnosed? Rectal biopsy can diagnose a case of systemic amyloidosis. Secondary amyloid A. Amyloidosis is abnormal. Important complication. Secondary amyloidosis is an important complication of rheumatoid arthritis, 20% of cases. Any patient with long-standing rheumatoid arthritis develops proteinuria or intractable diarrhea should be investigated for amyloidosis. So any patient having long-standing rheumatoid arthritis develops proteinuria or intractable diarrhea should be investigated for amyloidosis. Any patient with long-standing rheumatoid arthritis who develops proteinuria or intractable diarrhea should be investigated for amyloidosis. Normochromic normocytic anemia or anemia of chronic disorder is very characteristic of rheumatoid arthritis, but due to NSAID, patient may develop hypochromic microcytic anemia. Atlantoaxial subluxation, this is the most common inflammatory joint involvement involving the spine. So it can causes atlantoaxial subluxation, atlantoaxial impaction, or subaxial subluxation. So it can lead to sudden cervical cord compression and sudden death. It can lead to sudden death. So X-ray spine inflection and extension should be done with MRI of the spine. And if required, neurosurgical intervention should be done in time to prevent sudden death. Management: patient need DMRD, steroid. There are some non-pharmacological therapy. So what are the first DMRD? Methotrexate. The first line of newly diagnosed active rheumatoid arthritis should be treated with methotrexate. So there should be combination of steroid and DMRD. So DMRD should be increased over 12 weeks, and steroid should be reduced over 12 weeks. So, and after 12 weeks, disease activity should be monitored in every 6 weeks, and if it is controlled, then single DMRD. If it is not controlled, then double DMRD. If it is still not controlled, then DMRD with steroid. If it is still not controlled, then there may be some requirement of biologics. So that is the treatment protocol. Methotrexate is the core drug of rheumatoid arthritic patient by treating DMRD. So it should be prescribed with folic acid in a minimum dose once weekly. So we should monitor complete blood count and liver function, and respiratory function we should be monitored who are getting methotrexate. So methotrexate can cause pneumonitis. So if any patient develop pneumonitis, or if there is any abnormal liver function, or their patient developing bone suppression or myelosuppression, so the methotrexate should be stopped or hold. There is second, like sulfasalazine, azathioprine, leflunomide, and hydroxychloroquine. Those who receive hydroxychloroquine, regular ophthalmic examination should be done because it can cause chloroquine retinopathy. So how we should monitor? We should monitor by checking the complete blood count, kidney function, liver function, liver albumin. So every 2 weeks until it should be done every 2 weeks until stable dose for 6 weeks. Then monthly on stable dose, then monthly for 3 months, then every 3 months it should be monitored. It should be treated by rheumatologist if patient develop leukopenia, or patient develop neutropenia, or kidney function is increased by 30%, or patient develop eosinophilia, or patients ALT or AST more than 100 unit, or platelet, patient develop thrombocytopenia, or patient develop hypoalbuminemia. So patient develop leukopenia, neutropenia, eosinophilia, thrombocytopenia, abnormal liver function, abnormal kidney function, this should be treated by rheumatologist. How we can monitor a patient of rheumatoid arthritis? We can monitor by checking number of the tender joint, number of the swollen joint, by checking the ESR CRP, and by checking the patient's well-being. About patient's well-being, checking the patient's well-being. So there is DAS 28 criteria. So by DAS 20 we can monitor the activity of rheumatoid arthritis. So the advanced disease is tumor necrosis factor inhibitor, some biologics like etanercept, infliximab and adalimumab. Etanercept, subcutaneous administration twice weekly, infliximab IV administration, adalimumab subcutaneous administration. So what are the adverse effects of tumor necrosis factor? Reactivation of latent TB, risk of TB reactivation. So TB gold test is very important during starting of biologics. Any patient with active TB should receive standard chemotherapy. Patient with past TB who have received previous adequate therapy can be started on anti-TNF alpha therapy, need to be monitored regularly. Interferon gamma release assay, that is the quantiferon TB gold test, is very important to find out any latent TB is present or not. So this is not affected by previous TB or previous BCG vaccination. Positive testing indicate a need of anti-tuberculosis treatment along with biologics, for example isoniazid. MON2 test is less indicative for prior infection because it is likely to evoke a positive reaction in patients with previous TB or who are previously having BCG vaccination. A patient with normal chest X-ray who have not started immunosuppressive therapy, a tuberculin test may be helpful. Rituximab is a anti-CD20 monoclonal antibody, results in B cell depletion. So it is indicated in advanced rheumatoid arthritis. NICE recommend rituximab in combination with methotrexate to be administered. A patient of rheumatoid arthritis who have persistent lymphadenopathy may be complicated by development of non-Hodgkin lymphoma or ITP. So that should be followed and monitored. Rheumatoid arthritis and pregnancy. There are some key points to be remembered. Patients with early or poorly controlled rheumatoid arthritis should be advised to defer conception until the disease is more stable. So until the disease is stable, the patient should be advised to defer conception. Rheumatoid symptoms tend to improve during pregnancy but only resolve in small minority. Patients tend to have a flare during delivery or following delivery. Patient should be referred to obstetric anesthesiologist due to risk of atlantoaxial subluxation. Methotrexate and NSAID. Methotrexate is teratogenic and NSAIDs are contraindicated during first trimester. Methotrexate is not safe in pregnancy, need to be stopped at least 3 months before pregnancy. NSAID may be used until 32 weeks, but after this time should be withdrawn due to risk of early closure of ductus arteriosus. So NSAID maximum can be used up to 32 weeks. Leflunomide is not safe in pregnancy. So what are safe? Prednisolone, sulfasalazine and hydroxychloroquine. Prednisolone, sulfasalazine and hydroxychloroquine are safe in pregnancy. Steroids are relatively safe in pregnancy if it is given in low doses, that is less than 20 mg daily. Low dose steroid may be used in pregnancy to control symptoms. The routine use of the oral calcium and vitamin D supplementation should be given. Sulfasalazine can be used throughout all stages of pregnancy and it is compatible with breastfeeding, although patient should be advised rare possibility of slow patient of the rare possibility that the mother is a slow acylator. Azathioprine can be used in pregnancy. Sulfasalazine and hydroxychloroquine are not controlling. During pregnancy, continue the current dose of azathioprine and add folic acid. Breastfeeding is not recommended with azathioprine. Prednisolone and hydroxychloroquine may be taken while breastfeeding.